Hello everyone and welcome back to Desert Docs, a junior doctor's guide to Central Australia. This is a series all about the unique medicine and working life that comes with operating in Alice Springs and the greater Barkly region, whether that be Alice Springs Hospital, Tennant Creek Hospital, primary care, or in the skies, as we'll cover today. I would first like to acknowledge the lands on which this podcast is recorded. Desert Docs acknowledges the Aranda people of Mantua. We recognise their custodianship, their continuing relationship with country, and that we work on their stolen lands. My name is Dr. Indi and today I will be talking to Dr. Dan Adams, Director of Central Australian Retrieval Service and Fellow of the Australasian College of Emergency Medicine. And I've also got Jo Talman, Alice Springs-based Operation Manager and Flying Nurse at Royal Flying Doctor Service SA and NT. So thanks, Jo and Dan, for coming on. Would you like to introduce yourselves and tell a bit more about yourselves to listeners?
I'm Dan. I am the Director of the Central Australian Retrieval Service, which kind of goes by many names. I think, within the halls of the hospital, we tend to be called MRACC. And in fact, I think service has kind of been verbified. So people MRACC get MRAC'd to places. And we're also really, I guess, structurally the Department of Retrieval Services, a little bit like the Department of Pediatrics or something like that. It's a bit of a unique arrangement, but that's what I do most of my time. So I spend 3 weeks in retrieval. I do a week as one of the staff specialists in the ED as well, just to keep things fun. And that's probably all there is to say.
Thank you for having me. I'm Jo Talman, as you said. I have been a flight nurse with the Royal Flying Doctor Service SANT for the past 4 years, so flying around in the skies to wherever Dan and his team send us. I'm helping out patients. I've just changed across to operations in the last couple of months, so now I'm working with logistics and where we send our planes and how we send them and having all the teams working together.
So it sounds like there's a lot of titles and names and logistics happening. And for a junior doctor like myself who comes to Central Australia to work for the first time and has no idea about the logistics of getting someone from out bush into a hospital, we'll start off by asking, how does the retrieval centre work in Alice Springs?
Yeah, so MRACC, which is a part of the Central Australian Retrieval Service, is sort of where things would begin in the patient's retrieval journey, I suppose. So MRACC is short for the Medical Retrieval and Consultation Centre. And what will generally happen is a patient will be at a remote area clinic or perhaps in a hospital like Tennant Creek, and the person with them will identify that they've got a problem that might need retrieval or that they need emergency medical advice. And they'll make a call to MRACC and have a chat first with one of our nurses and then with one of the MRCs or medical retrieval consultants, where a decision will be made around the management plan and if retrieval is necessary, the urgency of that retrieval and the most appropriate platform.
So how many doctors work in MRACC? What kind of things need to be organised from the call that someone makes from that remote clinic coming through to MRACC, to the nurse, to you?
Yeah, well, so I think a lot of the people involved are outside of MRACC itself, and of course RFDS are heavily involved and they do a number of the parts of the planning for the patient and treatment of the patient as well. But there are also the remote area nurses that are on the ground out looking after the patient in the first place, or if it's not a clinic, it may just be the station manager or the mine site paramedic or the inpatient team at the hospital that the patient's in. Aside from all of those people, in the retrieval service itself, you will have on shift at any one time, we'll have one nurse sitting in the office. They're our nurse coordinator. And we'll have one MRC on in the morning and we have another MRC on in the afternoon. And then we have a single night doctor who is colloquially known as the NED, the Night Everything Doctor, who is on call to fly with RFDS if that's necessary, but also is, if they're in the office, taking calls. That's the staffing for MRACC. And then separately to that, we've got our flight doctor cover, and in the morning we'll have a single doctor on and then a second doctor who sits on standby, either off-site or in the office doing some non-clinical work, and then another doctor that comes online at 1 o'clock in the afternoon aligned to the day 3 plane that RFDS has. So we call it the day 3 doctor, which is a little bit confusing, but it's the afternoon doctor, and then the next doctor that comes online is Ned.
So we're talking about a 24-hour service here, Dan, is that right?
Absolutely. So every single day of the year. It's a bit like an emergency department. It's a remote emergency department, and I think we in many ways operate the same as that. So 24 hours a day, 7 days a week, 365 days a year, and sometimes operating, as happened yesterday, through some pretty challenging tech issues, like our phones going down.
And Jo, would that hold the same for RFDS? Well, you are catering to the retrievals that have a doctor provided by MRACC, and you're facilitating the planes. What else is facilitated by RFDS, Jo?
Absolutely. So we follow very similar shift patterns with the RFDS aligned with the MRACC shifts as well. So for every shift that we have a nurse and a pilot that are associated with that shift that are dedicated for that exact shift. So for us, we call a day 1, which is during the day, a day 2, which is usually our long haul flight nurse and pilot. We've got the day 3 that Dan spoke of, and then more recently we've added a second night shift as well. So that's where we start to differ a little bit. We've got 2 nurses and pilots on overnight now to help assist, as Dan touched on earlier, with the RANs and the workload that we can see in communities or out on the stations at time to help relieve on a quicker basis.
Yeah, always hard to see what little changes like that are going to, how they're going to be utilised and what the result's going to be. But that's a good example of something that we've ended up using both those crews a lot more than I think even than we thought we would. So they made I think a really big difference to the fatigue levels out there and how long people have to wait once sun goes down to get picked up.
So tell me about these planes. I know that the planes can be called day 1 plane or day 2 plane. How many planes are operated by MRACC and RFDS, and how big are they? What are their restrictions, and how do we choose which one to use?
Well, we operate no planes, MRACC directly. RFDS operate the planes. So I'll let you speak to how many you've got around.
So we've got 2 different types of planes here in Alice Springs. We've got 4 aeromedical configurated PC-12s. So they're our main little workhorses here in the territory. They are set up with 2 stretchers and 3 seats. So usually we can have 2 stretchered patients or 2 sitting patients. However, if we're doing a more urgent transfer and we've got a doctor included, one of those seats is dedicated for a doctor, one for a nurse. And then for our longer haul flights, we also have the PC-24. So that's an added stretcher. That's a 3 stretcher plane with seats associated as well with that. The ability of both the planes is we can cater for the needs of what we're going to. So we can plus or minus seats according to if we mainly have sitting patients of lower acuity, or do we need the stretchers for higher acuity, or gear transfer for places such as stations that don't necessarily have all the gear that we would usually see in a clinic setting.
And what's the range of these retrievals we're talking about? You said long haul. Exactly how long haul are we talking?
So, currently we cover about 1.2 million square kilometres of the territory and down into the APY lands as a catchment for our modified primaries.
Yeah, and a little bit into WA as well.
Yeah, so we go Barkly Tablelands across to Western Australia, into Kirikura, up to Elliot, and then down to Marla. Well, in Dalkana, isn't it? Sorry.
Well, we pick up from Marla, even though the clinic is in Dalkana. It's a bit of a weird arrangement, but yeah.
So in a PC-12, obviously a lot slower to fly in, so that can take a bit of time. It can take up to an hour and a half to get to the Western Australia border into Kirikura, and then do whatever we need to do and come back. But when we're talking long haul flights, we're usually talking up to Darwin from Alice Springs, or down to Adelaide, or even across to Melbourne. We've done a couple of times in the past few years. Yeah,
we went to Perth. We've done a few unusual locations now with the PC-24. Just gives us that extra range to bring the patient to the ideal location. So we're not quite so tethered to Darwin and Adelaide as the tertiary centres as we have been up until, how long have we had the jet? 18 months?
12, 18, yeah.
And Jo, you mentioned that sometimes doctors will go on these flights, and Dan, maybe you can shed some more light on which clinical scenarios would require a doctor to leave from Alice Springs go on the plane, go into the remote clinic and help out. And if you can provide an example of one of the more dramatic cases.
Yeah. So no problem. Yeah. So it's a sort of slightly funny arrangement, I guess. So we've got coordination done by the Department of Retrieval Services, or CARS, or MRACC, or whatever you want to call us. And then we sort of separately have this wing of the service, which is actually the longest standing part of the retrieval service, which is the flight doctors. We've talked a bit about their shift structure, but in a scenario where you've got a sicker patient that requires some quick care interventions that are, I guess, outside the scope of practice of one of the nurses, something like an intubation or sedation or central access and vasopressors and inotropes, the sort of patient that you might expect to end up in ICU, will designate that. We call it a doctor job, but RFDS call it a MAF, or a medically assisted flight. And in that scenario, when RFDS operations control, which is based down in Port Augusta, are able to activate a plane, they will activate their crew and they will simultaneously activate our doctor. And then the doctor will start making preparations to head out to the hangar to go for a fly, and they'll have a series of items that they need to bring along. The main item being our red bag, our red doctor bag. They need to bring an iPad. We've got a noise cancelling aviation headset for them, and there may or may not be additional equipment as well. We've got a Credo box filled with some blood and a fluid warmer. We've got an ultrasound machine, or a couple of different choices of ultrasound machine, and occasionally there's extra things, the surfactant if we are going out to a potential preterm labour. It's probably the main stuff that we are bringing out of the hospital. And then we'll jump in one of our cars and head out to the hangar. By the time we get there, Jo or one of the other flight nurses will have arrived and be packing the plane with the equipment that RFDS bring, which is also quite a significant amount of equipment, and for the sort of job that a doctor would go out to, where we really thought that they might need, the patient might need all the things, then they'd be bringing their ventilator, obviously their Zoll monitor, the vac mat, bunch of infusion pumps and syringe drivers, and we'll often kind of rock up and they'll be just about ready to go. We'll bring it all out to the plane and then jump on board and get going. So let's say we had a patient arrive, totally theoretical scenario, let's say Elliott Clinic, a little bit over 2 hours away, and the patient arrives febrile, tachycardic, hypotensive, hypoxic, with a productive cough and pleuritic chest pain, and it sounds like the patient has pneumonia. We would get started supporting the remote area nurse in that clinic to stabilise the patient as best they can, making sure they've got a couple of peripheral lines in, doing a fluid bolus, getting the antibiotics in, getting the blood cultures, and doing some point-of-care tests. Classically, the ISTAT tests are available, so the CG4 and the Chem8. If they've got some chest pain, we'd probably do a troponin. If they're tachycardic, we'd probably do an ECG and see where we land after all of that. If they're really unwell, we can immediately call OCC and say, hey, we've got a sick one that we want to verbally activate right away. And we can and will do that. We've got 7 tiers of urgency, and if it's a P1 or a P2, then we can and will verbally activate the crew, and we'll just let them know over the phone, hey, this is where we're going, this is how much the patient weighs, if we know it, this is their name, and this will need a doctor, and it'll be Dr. X. And then we'll crack on with managing the patient in the clinic. Of course, if we get a fantastic response to treatment, then sometimes we say, hey, actually, it's probably not as urgent as we thought, and maybe the other job that has been waiting a little bit longer should go first. But oftentimes the case will continue as planned. But I guess the key thing there is that MRACC is continuing to maintain clinical governance over that patient, continuing to provide clinical support to the people on the ground, while we're simultaneously arranging to come out and collect that patient. And we can be dynamic, Of course, the other things can go the other way as well, where the patient unexpectedly deteriorates. That same exact patient who's maybe a little bit tachycardic and has a reasonable blood pressure might go on to develop hypotension, and we have to change it in the other direction and say, hang on, actually this one's going in the wrong direction despite our initial care. Let's bump up the priority. And then once the crew's activated, we'll go through the process that I just described of getting out to the hangar and meeting our nurse. And then what happens from there?
Yeah, so I think once you guys send the tasking as well down to Port Augusta, where our comms are, if it's the urgent case, the P1 or 2, they'll send the plane straight there. So that's when they start activating it. And for a lower urgency, that's when they start trying to pick up multiple people at the same time to make the to make the case as efficient as possible.
Yeah, so they're thinking about the whole board, as I often think about it, in terms of all of the outstanding jobs we've got. At any one time, we may have 4 or 5 or even more outstanding missions waiting for their opportunity to be sorted out. And of course, if it's an urgent patient where we've got to drop everything and go to them, we will simply drop everything and go to them. The majority of the patients are well enough that perhaps we'd go and get the sickest one, make sure that everything's under control, and then we would decide on whether or not we can stop by Tennant Creek on the way back and pick up a patient from there, or we really do just have to come straight back. And then some of that's thinking about, do they have an escort? Do we actually have the weight capacity, the payload capacity in the plane to take the current patient that we've got, plus the doctor, plus the nurse, plus the pilot, plus this child and the mother. Oh, and it turns out the mother's breastfeeding another child, and so we've got 2 children to come along. And so all of a sudden we might find we need to make a decision about who to pick up on the basis of who we actually can pick up.
Yeah, so then the tasking comes through. The pilot and nurse will be activated as well, so the pilot will come in. Depending on the acuity, they might have 40 minutes to get ready, or they may have an hour. So the pilot has to plan all these waits. So that's why when Dan rings up and says this is an urgent transfer, we'll get an urgent activation, but that's why they also give the weight, because that plans how much fuel we can take on the plane, as well as every single one of our gear is all weighed to a T, and there's no secrets between friends with weights between one another as well, because that's what dictates where we can get and how far we can get, and that we can get back safely. And that's where logistics and operations come into it all, because we have to be able to go to an alternate strip if weather persists like we're seeing at the moment. So
you guys probably need to reweigh me realistically, because I reckon your weight on files from 2016. But yeah.
Within a ballpark. But we'll choose our gear depending on that as well, and what the job is and what the doctors have told us. By that time, a doctor usually appears, and credit to the organisations being able to work so well together that they can communicate what we need, what the situation is, whether we feel comfortable going, or what extra things we need to take with us to make sure it's possible to deliver the best care that we can.
So we've talked about everything that happens behind the scenes when you're bringing a patient into Alice Springs Hospital, but there's a whole side of MRACC and RFDS that's all about bringing patients from Alice Springs Hospital to a higher centre if they're too sick for Alice Springs Hospital. So in my experience, some of those patients will be needing an MRCP, which they'll have to go to Adelaide for. They might have a pneumothorax and need a VATS and has to be transferred down to Adelaide as well. And that's something I'd like to touch on again with you, Dan, about exactly what are the considerations for requiring an MRACC or RFDS flight from Alice Springs. When can't they go on commercial flights with Qantas to the other hospital?
Yeah, that's a good question. And there are some pretty clear guidelines from Qantas, although they're slightly different from the guidelines from Virgin and Air North about who can and can't travel commercially. But yeah, you've clearly done a surgical term hearing those examples. The most common reason for transferring someone with RFDS still remains that they've had a myocardial infarction, and you describe it as the bread and butter of the system almost is the non-STEMI transfers that we bring down. It's something like 40% or 35% of all of the RFDS transfers that get done are people who've had a non-STEMI, and the majority of the people who've had a non-STEMI have had treatment in the hospital, and they no longer got pain, they've not had any arrhythmias, they've got no signs of heart failure, they're looking pretty well, they just need to go down for an angiogram, and Qantas say they've got to wait a week before they can do that, so we transfer by RFDS to do that. One of the really nice things about having the jet around, and I don't know that Jo mentioned it, but the jet is kind of the asset of choice for inter-hospital transfers. In fact, it's contracted for inter-hospital transfers specifically. With the 3 stretches now, it means that we've got a little bit more leeway to kind of wait until the plane can be filled for those patients that are very stable, who've had a non-STEMI, who just need to have an angiogram. So I think more and more now they're kind of being opportunistically transferred sometime in the next 48 hours or 72 hours even. Usually in that time frame, someone else who's got some other problem will crop up as well. And we can bring them all down together.
And you can bring people back from Adelaide in a repatriation flight, I'm aware as well.
We can. There's not a huge number of patients that need to be repatriated. Most patients have their problems sorted down in Adelaide, and by the time they are ready to come home, they're capable of travelling commercially. But there are a proportion of patients who need to come back with RFDS.
Yeah, I'd have to agree. I mean, especially looking at people who have ongoing pain requirements or analgesic requirements, or those who are unable to sit for a length of time, often will choose to sit on the stretcher for a repatriation flight.
Yeah.
Yeah, the classic repats are patients who are stretcher bound, perhaps at a baseline, someone who's had dual amputee or otherwise really deconditioned, and then the other group that I find interestingly need to be repatriated are those who are doing unusually well. They've gone down, they've had a cabbage, and Qantas won't let them go home until day 10, I think it is, and they're actually all right on day 7, and rather than take up a bed for another 3 days at the RA, they'll get referred to us at about that time, and then they'll come back with us. But we've classically referred to the return leg as the dead leg, which is kind of I hate the term, to be honest, but again, with a few more hours to play with the jet, because it takes half the time to get down to Adelaide in the jet, we've been able to use that return leg to, say, go up to Tennant Creek, which has been probably the most common thing that we've done on the way back, because we've got the hours to get there, pick up a couple of patients, and then come back to Alice Springs, which in turn frees up that day 3 plane to go and do primary jobs, which is just really fantastic.
So what happens if MRACC can't take a patient for whatever reason? What are the options and alternatives if you cannot? And what kind of restrictions would prevent MRACC from taking someone?
Good question. So what are the reasons why patients may not be able to travel with RFDS, and that we need to start getting creative? I think bariatrics is certainly one of them, and the weight limit for the stretcher loader is, I think, 180 kilograms. And then the weight limit for the stretchers itself is a little bit higher at 186 for the stretcher. So anybody who's over that weight, we start having to look at alternative modes of transporting them. That weight limit's higher than the PC12. And I think, there's also, if someone can sit in the chair and can climb the stairs, then you've got a slightly higher weight limit as well. So for a select few patients who need aeromedical transfer but are able to board via the stairs, you've got a higher weight limit. Anyway, it's kind of getting into the technicalities of it, but there is certainly a limit of, in terms of the weight for the patient, as well as separately a limit for the width of the patient, which I actually think is probably triggered before the weight limit usually.
I think the other biggest, I don't want to call it a restriction for RFDS repatriating people back out to country, but one of the things that we commonly come into issues with is the coordination of repatriating somebody back into country, because they're often going to an aged care facility or an in-hours transfer where it lines up with all parties to make sure that there's somebody suitable there as well to receive the patient, because obviously we're limited to the airstrip at the time as well. So whilst we can fly patients home and we can bring the amount of luggage that they have with them as well, making sure there's someone at the receiving end to get them to where they need to be and make sure they're looked after as well is something that MRACC is in charge of coordinating and discussing. So I think that's probably another thing that stands out to me.
Yeah, repats to community.
Everybody.
Yeah, repats to community are more complicated than repats between the Royal Adelaide and Alice Springs, for instance. And it's you're right, there's a certain amount of equipment that can go on the plane, but there's plenty of stuff that can't as well. We've had issues with oxygen concentrators that just need to be sent out ahead of the patient, and wheelchairs and things like that. So we need to make sure that the equipment that they need has made it to that location. And some of these places are so remote that it takes a long time for that stuff to get out there. And then we also need to make sure that we've got a plan for handing over to someone who is able to receive, and that when they get to the community, they've got a bed to sleep in that night, and that everything's ready to go. So
lots of discharge planning.
Lots of discharge planning, and that requires the involvement of the inpatient team and the accepting clinic and the accepting aged care facility and all that sort of stuff. And sometimes we're really pressed for time too, because repatriating people to community who require an aeromedical transfer is really often a part of the end of life plan for that person, and we're bringing them home to die on country sometime in the next couple of months, if we're lucky, but sometimes it's in the next couple of days.
So I think that covers repatriation to country for patients who are unable to go by alternate means. And I'll just touch quickly on the alternate means that we've encountered in Alice Springs, which is private car, bush bus, sometimes ambulance cars taking someone out, and then a private car meeting them on the road. Halfway meet.
There's a halfway meet or a road rendezvous. I prefer the term road rendezvous because it doesn't set anybody up for false expectations. One of the two parties will inevitably have gone more than halfway. So road rendezvous is just a little bit easier to break down. You've touched on a few modes of transport for patients, and we didn't really mention it before, but actually RFDS only do about 3/4 of the transfers that we arrange through MRACC. Quite a number of them are road rendezvous with St John's and the clinic vehicle, or private vehicle transfers, and sometimes the private vehicle transfers are relatively urgent individuals. That's just that they don't necessarily need monitoring or active treatment en route. So maybe a nasty ankle fracture or something like that would need to come in and would come in by a private vehicle. We've also got the bush bus that you've mentioned. We've got the Greyhound that does a lot of the heavy lifting for patients that are up in Tennant Creek overnight. And then we've got commercial flights. So we've got the Chard Air plane that comes a couple of times a week, as well as the mail plane and the SONT flights that are travelling around, dropping off inpatient specialists doing clinics somewhere. And so we'll keep tabs on all of that, and we'll utilise any of those means of getting people in. And not infrequently we can avoid an aeromedical transfer just because there happens to be an alternative like one of those around. And our doctors will hop on the ambulance with St John's. It doesn't happen all that frequently. I think it's about 95% of the jobs that the doctors do are heading out with RFDS. But every month we do certainly get on an ambulance and go out with the paramedics to pick someone up, classically to those places that are a little closer. Santa Teresa, Hermansburg, Tea Tree, Tichikala, Harts Range, perhaps about as far as we would go under ordinary circumstances.
And I will just mention here that the MRACC and RFDS service services an area the size of Germany, I believe, in that area, NT, SA and WA that we spoke
It's a big area. And I don't know, yes, you might know, Jo. I've started saying this and we think it's true, but I haven't had it independently verified. But I understand that the Alice Springs Retrieval Service covers a wider area, a larger area than any other single site retrieval service in the country. Obviously Western Ops has a whole number of different sites, but individually each one of those sites doesn't have a catchment the size that Alice Springs has. And that's true down south in South Australia where they've got more than one site. But the nearest site to us up north is Darwin. The nearest site to us down south is Port Augusta. The nearest site to us out west is Kalgoorlie. The nearest site to the east is Mount Isa. So we've got a huge catchment to cover.
Yeah, and speaks to the remoteness of working in Alice Springs and seeing patients from all walks of life come through the ED doors and onto the wards and interacting with such a large spectrum of different people from different backgrounds.
It's pretty cool to be able to get out there and see so much of the country.
Thank you so much, Dan and Jo, for coming on Desert Docs today. It's been really nice to really tease out the difference between RFDS and MRACC and get a bit of a taste of how difficult and challenging and rewarding the job is, and how both the services have a lot of teamwork to enable patient care.
Yeah, we work really well together, and thank you very much for having us along.
Thank you.
Desert Docs, a junior doctor's guide to Central Australia, is an NT Health Media podcast produced with the help of ACCC Studio.